Thank you very much, Janine. MEC for Health, Dr. Gwen Ramokgopa, Professor Ames Dye, the head of the Steve Biko Center for Bioethics and Law at our university, representatives of the Biko family and of the Biko Foundation, Professor Veriava, who's been a long-standing member of the board of the Steve Biko Center for Bioethics and has chaired that for a long period of time. Distinguished guests, colleagues, ladies and gentlemen, good afternoon. It is indeed a great pleasure to welcome you today to the Faculty of Health Sciences and the University of the Witwatersrand on the occasion of the 2017 Steve Biko Bioethics Symposium, which is auspiciously being held on the 40th anniversary of Steve Bantu Biko's inappropriate and premature death. Ladies and gentlemen, it is a great pleasure, therefore, this afternoon for me to welcome our guest speaker, the MEC for Health in Gauteng, Dr. Gwen Ramokgopa, and to give you a very brief introduction of this remarkable individual. Dr. Ramokgopa was born in Attridgeville. She graduated MBCHB in 1989. My apologies. She has also obtained a Master's in Public Health in 2007 and has additional postgraduate qualifications in health economics and financing and in strategic management and marketing. Dr. Ramokgopa, after qualifying, worked as a medical officer at the then Ga-Rankuwa Hospital until 1992, when she joined the Independent Development Trust as a National Health Program Manager. In 1995, she was invited by the MEC of Health to participate in the strategic management team and later as a medical advisor, where she assisted in the establishment of an integrated, unified and de-racialized Gauteng Department of Health. From 1998, she became a member of the Gauteng Legislature, serving as the chairperson of the Portfolio Committee for Health, as well as for the member of the Portfolio Committee of Finance and Local Government. Dr. Ramokgopa served as a member of the Executive Committee for Health in Gauteng from 1999 to 2006. During this period, she also chaired the Social Development Committee, served as a member of the Political Labour Committee, coordinated the government multi-sectorial AIDS program, and was head of the Gender Mainstreaming and Women's Development program within the Gauteng government. Between 1995 and 1998, she became the first black woman to chair the Executive Committee of the then City Council of Pretoria, and she was later appointed to serve as the Executive Mayor of Tshwane from 2006 to 2010. As you all know, in February of this year, she was again appointed as the MEC for Health in this province. Apart from many of the other important positions and functions that Dr. Gwen Ramokgopa has held, she has also served on the University Council of the Medical University of South Africa and of the Pretoria University, and currently is the Chancellor of the Tshwane University of Technology. In her various roles and responsibilities, Dr. Ramokgopa has demonstrated a passion and commitment on issues of policy, leadership and strategic planning, corporate governance, ethics, accountability and participatory democracy, economic development, youth empowerment and gender equality, as well as excellence, quality assurance, innovation and research. And as an anti-apartheid activist, she occupied various leadership positions, including the student movement, women's organizations, professional health organizations, and in the African National Congress. Ladies and gentlemen, I'm sure that you will agree with me that Dr. Ramokgopa is ideally suited to give us a talk today on a just health system, our common vision, and it is my privilege to now invite her to do so.
Good afternoon, and thank you very much, Professor Velema, and also to Professor Martin Vella for the warm introduction. I always thought I was a fossil. It's almost confirmed today. And I also want to acknowledge the invitation to present this very important, it's actually an honor and a privilege for me to present this lecture, Steve Biko Bioethics lecture on the 40th anniversary of the death of this fine African young man who was an activist, an intellectual, a freedom fighter, and indeed a martyr for justice and the freedom that we today enjoy. I would also like to thank the director for the Steve Biko Center for Bioethics, Professor Ames Dai. I also want to acknowledge the presence of Professor Kuvadia, Professor Veriava, and many other distinguished professors that are here. And indeed, it is befitting because if given an opportunity to prove himself, we all agree that hopefully that Steve Biko could have been one of the intellectuals and perhaps scholars of our times. I want to acknowledge also amongst us the presence of the family representatives of the Life Acid Many Tragedy, who are here with us to share with us their experiences, and Date Lucas Mokwerane, and distinguished guests, ladies and gentlemen, and particularly the young people, the 35 years and younger, because the life we're celebrating today was a young life. Indeed, an ordinary young man who extraordinarily made a profound impact on society. As preparations to mark the 70th anniversary of the Universal Declaration of Human Rights by the UN for all peoples of the world unfold, which will be next year, it will also be time to reflect on how far we have gone in building on the foundation we have together made during the period of the Millennium Development Goals. And also, it would be time that we assess how far we've gone in the implementation of the UN Sustainable Goals for 2030, in particular Goal 3 that binds us, I quote, to ensure healthy lives and promote well-being for all at all ages. We must never forget, though, that it would be a substantive recognition of the contributions of those that have made sacrifices, like Stephen Bantu Biko, for us to work together to make advances beyond where we are, to even succeed in our endeavors in achieving the milestones of those goals, and beyond that, to celebrate excellence in a common effort towards the ideals for justice. And these are the ideals that many sacrificed for. We must together commit to translating the sometimes analysis paralysis we get entangled into positive actions, and also translate the proclaimed rights that are well written of to everyday reality for ordinary people. Our common vision must spur us to work together as government and society, holding one another accountable towards arriving at the justice in health that must be progressively realized. My argument is that the vision for a just system, whether in the economy, whether in health, whether in society in general, is a vision that must belong to each one of us. It can't belong to institutions and establishments. Institutions and establishment are not able to reflect. Institutions and establishment from time to time are visited by individuals who come, make a contribution, and move on. If the ideals that we subscribe to, that many indeed have sacrificed for, are not amongst us as a people, are not amongst us as a common vision, there is a real risk that those ideals can be deferred or even derailed. Bantu Stephen Biko represents a generation of youth that uncompromisingly and resolutely advocated for a society that guarantees peace and democracy within the paradigm of a human rights culture as well as equality for all. This is a generation whose liberated minds refuse to be imprisoned by even one of the most sophisticated architectures of modern-day slavery, the apartheid system that was enforced by unbelievable levels of brutality. These young people envisioned a future of freedom and a shared prosperity for all. They were free in their minds. They knew that indeed the ideals that they were prepared to work towards are real and are achievable. I must say that I was really privileged, although pained at thinking back that opportunity that I had to attend the memorial service of Stephen Bantu Biko, which was held in Atteridgeville, my hometown, at my church, St. Bennett's the Martyr. The nation was mourning. And as you may know, Steve Biko could not complete his medical studies due to his involvement in the struggle for liberation. That this Bioethics Institute at the Wits University and the academic hospital associated with the University of Pretoria are named after him should be viewed as a recognition of both his unfulfilled dream of being a doctor, translated into being recognized by health institutions that train doctors, amongst others, on one hand, and on the other hand, a recognition that even the doctors who were duly registered as medical professionals conspired with the apartheid regime and failed him, and that naming these institutions after him could be a one way of saying, we wish as a health profession we could have done better. Fellow South Africans, I've been requested to focus my lecture on, I quote, a just health system, our common vision, close quote. I suspect the expectation is that of giving an assurance that we are on track to ensure that we attain the ideal of a health system that represents the best of humanity, human solidarity, and equity, especially after the life-endangering mental health tragedy that saw more than 100 patients dying in the wake of the reported high medical costs, high litigations, as well as unaffordable healthcare challenges that we have. I hope I'll meet this expectation. There is now sufficient evidence that all the other sustainable development goals that have been adopted by the UN, to which we are signatory, have a direct and indirect impact on health at an individual level as well as at a national level. This is not by any accident of history, but through concerted efforts of activism, scholarship, and advocacy. Human civilization has come a long way in acknowledging and institutionalizing two critical aspects of justice in health. Firstly, that health is essential for socio-economic development as much as development is for health. I see quite distinguished leaders in health amongst us who have led these debates when we were still students, and I want to give recognition to their contribution and efforts. But unfortunately, the health in all policy has not adequately taken root in most financial and economic sectors. Thus, health expenditure is not sufficiently being appreciated as an investment, but still as an expense. Together, there's a need that we take up the struggle of health in all policies so that we can advocate for the implementation of the National Health Insurance Policy that has just been approved, and in particular, the Health Promotion Council of South Africa that is being proposed in the Act. I'm aware that many of us have not had an opportunity to go through a rigorous inquiry of what this National Health Insurance White Paper says to us today and what our individual and collective contributions should be. I would want to invite all of us today to Google. Thanks, Google is there, to provide us with the documents. Let's visit this document. It's just but one of the milestones towards universal health coverage. So firstly, we must celebrate that there is consensus, including by the World Bank, that health is essential for socio-economic development as development is for health. Secondly, we must also celebrate that health is now increasingly acknowledged globally as a fundamental human right, and further that the goal of achieving the highest attainable standards of health is subject to progressive realization. Of course, an ongoing commitment depending on available resources. Universal health coverage and the NHI policy are but vehicles towards achieving this ideal. And us as people of South Africa need to understand what this means for us, and we need to work together to create a dispensation that will suit us. I must pause here because in engaging with a number of stakeholders, people are disgruntled that the NHI white paper is not exactly as they had wanted to see it. But perhaps if we look at it as but one of the stepping stones, we can look at implementing areas where we immediately agree that they be implemented with a sense of urgency as we engage towards shaping the universal health coverage system that will be suitable for the majority of South Africans within the context of health as a human right, equality, and justice in health. Steve Biko once said, and I quote, "A people without a positive history is like a vehicle without an engine," close quote. We need to look back as a South African people on the journey that we have traveled towards the ideals we want to achieve. I have a problem that sometimes we focus on what we don't as yet have achieved and not adequately on what we need to build on. It is human nature. Being a global citizen, we must be proud that South Africa has a very rich history of struggle and advocacy for equality, equity, and justice in health. It's not a foreign ideal that is imposed on us by some UN declaration or treaty. It is what we have contributed to the global agenda as well. From the era of the African claims, the work of Dr. Klugman, the Freedom Charter, the ANC Health Plan of 1994, the South African Constitution, which has a Bill of Rights, and recently in the National Development Plan 2030, which has been adopted, which is a very rare find these days, by all the political parties in the South African Parliament. The NDP was supported by all parties. Through the perspective of health in all policies, and recently the multi-sectoral approach to fighting HIV and AIDS epidemic, we are realizing a decline in child and maternal mortalities in South Africa. We're getting closer to zero transmission of mother to child, from mother to child of HIV. We are also seeing death rates that are decreasing nationally and in our province. And in what the UNAIDS refers to as an epidemiological miracle, life expectancy at birth has increased for both males and females in the past few years. We are on track towards achieving the goal of life expectancy of a minimum of 70 by the year 2030. We don't mean that if you are 80, there is a mistake. We mean a minimum of 70. With this progress and with this rich history of our people, and within the global context of consensus on most of the important indicators that we are on the right track, why should we then be concerned as a people? We must acknowledge that development and evolution is not linear, and there is always a constant contestation of contending forces with unequal access to scarce resources. Those who have resources, either intellectually or financially or even closer to power, are more advantaged to influence the course of events and the direction of the path than those who are least resourced. And we as South Africans, as a people, and even as people of the world, we must decide whether this is the development trajectory and the evolution of human advancement direction that we want to allow. And if not, are we ready to embrace human solidarity so that we focus at all material times on the least resourced amongst ourselves. Without being alarmist, there is a real risk of both the public and private health systems in our country not being able to meet the health needs of the population if we do not remain vigilant, as indicated by the following 5 areas or developments. Firstly, and I have beautiful slides in this regard, but Professor Dai said I communicate better when I'm facing the podium and the people than when I'm trying to talk on slides. These 5 areas that must concern us. Firstly, is that there's a decline in the medical aid coverage of the population that has medical aid due to largely economic hardships and market failure. There is apparent, it may be real, poor management of our economy, poor leadership, and also uncontrolled commercialism of health as a public good. That is contributing to these economic hardships in general and also in market failures. And where do these members of society go if medical aid no longer can cover them? They come to the public sector. Secondly, there are high levels of high levels, including high costs of medical litigation affecting both the public and the private sector. Perhaps the most published are in the public sector. But we are informed that there are communities where there is no longer a private obstetrician to serve them because of these high litigations. There are medical, legal, and other contributing factors in this regard. It's a subject matter that we must deal with at another time. But it's an indication that there are risks that our vision of justice in health may be derailed. Thirdly, the decline in the budgets of the public health sector, in particular goods and services budgets in real terms, are resulting in high accruals, deferred payments of essential services. That's really what it means. Some argue that it is because of the high costs of compensation of employees that are crowding out goods and services, which has to purchase medicines, equipment, and all the consumables to provide quality health. I think we should engage in that debate and see whether that is the reason, or is the reason the underfunding of goods and services, and or the relatively higher cost of the medical inflation. Fourthly, the quadruple burden of disease remains stubbornly high, even though we are seeing declines in certain areas, like HIV, TB, amongst others, and children's vaccine-preventable diseases. And unlike other countries, developed countries, the burden of disease in South Africa is both of developing and also developed country's profile. We have a high burden still in communicable diseases, diseases of lifestyle, still high levels of maternal and child health, as well as high levels of trauma and violence. I'm not sure whether we should allow our children to be with us when we watch news, when we come home, because one of the first things I do, which I guess most of you do as well, is to go to the sofa, maybe with a plate of food or something to drink, switch on the TV and try and check the news, the stories for the day. Many of these programs on TV presents to us the unacceptably high levels of tensions in society, high levels of violence, and indeed trauma that translates into this quadruple burden of disease. The fifth is the increasing levels of poverty, unemployment, and inequality. Recently, the Statistician General released data that shows that 1 in every 2 South Africans lives below the poverty line. We are also starting to see the re-emergence of severe malnutrition, which were almost eradicated by the social security net that was put in place during this democratic era. We cannot sustain these high levels of inequality. South Africa has the highest level of Gini coefficient in the world. It is unsustainable. I would like to argue that whilst the private health sector and civil society organizations that provide health services do this on a voluntary and complementary basis, the state is still obligated to ensure that it works with society in general in ensuring that the common vision of a just health system and equity in health is not lost. I further would like to argue that the public health system in South Africa, which caters for 84% of the population, remains one of the most important and precious assets of our democracy as citizens. And we should not let anyone put it at risk. Many of us still do not understand, however, how it was possible that the Life Esidimeni tragedy could happen in this day and era, in this province, which is so relatively well-resourced compared to others, and after so much has been achieved to date. Indeed, as we take a pause, I trust that the discussions that we'll have today with the rest of the panelists will be able to give us a glimpse into the lessons that we can learn. But I would like to invite interest from scholars so that we do not make a mistake of not fully appreciating how, why was it possible that we experienced this tragedy. And perhaps it's a challenge I'll leave with the Bioethics Institute. For our common vision of a just health system to remain on course, I would like to propose the following, which I'm using as pointers to check whether my contribution, having come back to the Gauteng Department of Health, to my old job, which is never easy to go back to your old job. You look for cobwebs, you look for the chippies you left underneath the table in this year or that year. You always have to ask yourself to acknowledge that there were those before you that have built on, that have cleaned up, that have polished here and there. But these are some of the ideas that I would like to leave for engagement, for discourse, and hopefully for support. Firstly is that there must be enabling and responsive institutional mechanisms that empower citizens to claim their right to health, and these institutions must be strengthened. In discussing with the families of the patients that were involved in the Life Acid Many project, many said they were completely ignorant of their rights. They didn't understand how to access services. They didn't know that the mental health review boards existed in their interest. They didn't even know at the time that there was an Office of Health Standards Compliance with a health ombud. So institutional mechanisms that empower citizens are critical. Secondly, that stakeholder involvement and participation as well must be institutionalized, including community-based, including amongst activists, including amongst scholars, those of us who are leaders in the academic and research field. We need to be able to infuse lessons that we may learn out of this in the work we do, so that we can really truly say never again. We also need to institutionalize stakeholder involvement amongst young people. They do not carry the baggage that we have. They are more futuristic, and they are also able to leverage the benefits and opportunities that many of us perhaps are too linear in focus to can see, as well as other sectors. Thirdly, I believe that there must be the multi-sectoral approaches to tackle socioeconomic determinants of health need to get even a greater focus. I must say that I'm a little bit worried that the Health Promotion Council is not reporting to the presidency, may still be in the health sector. Other sectors may ignore it. Fourthly, continuous sharpening of a human consciousness to care, to act, and to empathize without fear or favor needs to be inculcated amongst us, including the principle of zero harm by us who are at the clinical and even management spaces. And this human consciousness should characterize the health system. Why do we lose it from time to time? The report of the health ombuds say that some professionals, out of fear, committed or omitted. We need to understand more and more of this phenomenon. Fifthly, we need to scorn poor management. I actually ask from time to time whether any of us who are paid by the health system are owed maybe a cent or a percentage of our salaries. Management and ourselves as leaders in health, especially in the public health system, must be expected to account for the time, for the salaries, and for the opportunities that are at our disposal. We must also scorn the reckless use of resources. Every cent in the health system, whether public or private, must be geared towards justice in health and health for all as a human right. We need to put institutions in place to track recklessness, to name and shame the reckless, and to ensure consequences for those that overprice goods and services for the public sector, and those that also provide mediocre services, those that are where there is ineptitude and where there are corrupt tendencies. We must have transparent processes in how the resources, including the time that is entrusted on us, are used. The sixth idea, we need to invest in a culture of innovation and excellence, including the use of smart technologies, data analytics, research, as well as the celebration of excellence. The little bit of time that I got out of public office, I realized that many companies invest in searching for excellence in health systems, especially in the public health system. We work too hard to search for excellence, to recognize excellence, and to celebrate excellence. And perhaps that is why our energies are usurped by negativity when things don't go right. Because when things go right, we are not there to acknowledge and to celebrate. Last but not least, I believe we must invest in the mobilization of society to dialogue around the risk factors, some of which I've shared with you, and to tackle these together as we co-design a universal health coverage, the NHI in our case, that most appropriately is relevant to South Africa and that can close the disparities that are there. Just to share with you, and I have slides towards that, it's estimated that the public health system spends about 1,200 rands per population, or per person in the population, whereas the private sector spends about 12,000. This disparity cannot be sustained. I have no doubt, as I conclude, that all of us gathered here today embrace the global consensus of health being a fundamental human right and universal health coverage as a translation of human solidarity for quality health care for all when needed, and thus effecting this right. I have no doubt as well that all of us gathered here today share the need to understand and advocate for health as a human right and to make real that which is a common vision towards a sustained, just health system. I have no doubt, too, that we all deeply share the need to promote scholarship, dialogue, and social action as a quest to fill the gaps of what the Steve Bantu Biko Foundation identifies as gaps between identity, agency, citizenship, and social change in general, including in health. Unlike with the Biko's suited oppressors, we should not allow ourselves to be left cold by the deaths of the life-acid-many mental health patients, nor be left cold by the daily plights of patients that are subjected to long waiting times in the public sector, or even those facing catastrophic health expenditures in the private sector. Let me also say that the Department of Health in Gauteng belongs to the people of Gauteng. We have begun a process of strengthening the voices of staff, of communities, and of other stakeholders as partners. Already we have adopted recommendations of the Provincial Health Forum that was convened 100 days after I assumed office. Amongst them, that the voices of families must be heard in cases of involuntary and assisted patients through family committees. I'm also encouraged that the National Health Council has adopted a policy of mediation as a way of empowering patients in all our health facilities. And we will be updating our patient administration and records in this regard. We have established an interim patient safety and medical education advisory panel, which is co-chaired by Professor Veriava and Justice Klassen, to send a message of zero tolerance to medical negligence and towards zero harm to patients. We have established a high-level health committee to leverage the possibilities and the opportunities that technology and modernization presents for efficiency and improved patient experiences of our services, including in the reduction of waiting times at various stations in the healthcare system. We've already begun to register, to develop a population-based database as we work towards a national health insurance system membership for that system. Consultation with the private sector in this regard of using integrated health information systems has begun, and we endeavor to establish a province-wide health information management systems, especially for those who hop in and out of the public and private sector, not to be disadvantaged in terms of continued patient care. Fellow South Africans, Thomas Oliver, who is the editor of the Guide to Health and Healthcare Policy in America, states that what they found as startling progress in life expectancy and infant mortality for their country as a whole was offset by equally startling disparities in those same health outcomes across the socioeconomic groups and geographic areas. He further quoted Donald Shawn, a philosopher and systems analyst who believes in stable states of organizations and systems. In his book entitled Beyond the Stable State, he reflects that the loss of a stable state means that our society and all its institutions are in continuous processes of transformation, and that we cannot expect new stable states that will endure even for our lifetime. I'm now at ease. I'm not looking at what I did, what I didn't do when I was here. Together with management and other stakeholders, we have been able to understand as fully as we can where the health department is now and what else needs to do to transform it to a higher level. Secondly, the philosopher notes that we must learn to understand, guide, influence, and manage these transformations, and that we must make the capacity for understanding them an integral to ourselves and to our institutions. Thirdly, the philosopher also says we must, in other words, become adept at learning. We must become able not only to transform our institutions in response to changing institutions, which are learning systems. That is to say systems capable of bringing about their own continuing transformation. We must capacitate our systems and institutions we lead. Let us be of liberated minds and build on the rich history of a human rights-based culture of human solidarity, on the successes, including the epidemiological miracles that are globally acknowledged that we have achieved. But let us also take lessons from the gaps and the sad experiences and stories and the failures that we have experienced. Let's together take lessons from the journey traveled so far and root our vision, our common vision, towards justice in health amongst the people. If it is amongst the people, we will be closer to bringing health rights to them. We can get there quicker and in a sustained manner. The people, as Steve Biko and others have noted, are their own liberators. We are just at their service. I thank you.
Madam MEC, thank you so much for that very insightful and encouraging presentation, highlighting and emphasizing again health as a fundamental human right, with justice and health for all. I think those words resonate and will continue resonating with all of us after this talk. So thank you very much. Our next speaker will be Professor Bernard Janse van Rensburg, who's going to talk about post-life esidimeni. To give you a little bit of background on Professor Janse van Rensburg, he is currently the head of the unit at Helen Joseph Hospital and associate professor in the Department of Psychiatry in the University of Wits. He completed his medical training in 1983 at the University of the Free State and subsequently did a diploma in tropical medicine and hygiene, a diploma in public health, a fellowship in psychiatry, an M.Med in psychiatry, and completed his PhD at Wits in 2010. His background experience includes health planning and epidemiology. Come where we can see you. Come closer. Sorry, I kept looking around. Where is he? Come and stand here. Thank you. Background experience includes health planning and epidemiology, rendering and development of mental health services in public and private and academic sectors. You found it, thank you. Acute adult psychiatric care, long-term psychiatric care, community psychiatric care, including children and adolescents, under and postgraduate teaching in the faculties of health sciences at the University of Pretoria and Wits. Areas of interest include mental health care systems development, spirituality, and psychiatry. He's a member of a number of offices, amongst other things, the South African College of Psychiatrists, a member of the Colleges of Medicine of South Africa, member of Senate, World Psychiatric Association, chair of the local organizing committee of the WPA International Congress in Cape Town, secretary of the WPA section for religion, spirituality and psychiatry, South African Society of Psychiatrists, SASOP. He's the president there, 2016 to 2018, and member of SASOP Board of Directors since 2010. Bernard, welcome. Thank you very much for addressing us on this very important matter. I'm not sure if we need to turn the lights down. Can everybody see up there on the screens? Not so well. Do we have anybody who... I can try and dim it. Oh dear. Oh dear, I'm not sure we're going to be able to. Okay. Thank you so much, Bernard.
Good afternoon, everyone. This is, for me, a big privilege to be here, and thank you so much to the Steve Biko Center, Prof. Dai, It's a great privilege to be here, and so thank you to being introduced both as an individual clinician as well as part of a collective group. And so, if anything, our MEC's lecture has just emboldened us to be able to make a small contribution and try to put professionals' voice on the table as well. In doing that, I will just also have to acknowledge exactly that as an employee of Gauteng Health, a joint employee of Wits University, acknowledging, you looking at the audience, my CEO and all the other head office managers, national health managers, as well as our faculty managers. So in that capacity, to be able to present a few minutes in terms of perhaps as an individual clinician and individual group of professionals' experience in terms of the Life Esidimeni context, it's clear that the MEC's lecture has not just only covered mental health per se, but it is of significance, I think, that this issue has been part of the 40th anniversary of the Steve Biko commemoration. And so thank you very much for being here. So in the next 10 minutes, I would like to just allude to a few points in terms of the role of clinicians in this experience, under the heading really of post-Life Esidimeni and how to move on from there. So I want to use one or two slides just to allude to the main errors that was pointed out by the Health Ombuds. The question as to what clinicians did or didn't do was interrogated by the Ombuds himself. I want to just introduce the theme of clinicians as advocates, and then perhaps the question of overhauling the system per se, and then looking in a comprehensive manner into the mental health care system, referring in particular to recommendation 16 of the Health Ombuds at the time, which I think set the tone already then. So just very briefly, quoting from the Ombuds report, he highlighted the following points as the main errors that have been made in the process and the project. Firstly, that patients were discharged into a community or district mental health system with no resources identified with that. Secondly, that the decision was made to so-called save money, as if community mental health care is a cheaper option. Thirdly, that there was an underestimation of the level of care that is required. The extent and the cost of assisted treatment care and rehabilitation services was highlighted by the Ombuds. And I think once again is already preempting the bigger integrated scenario post-Life Esidimeni, in that it happened with a lack of holistic integration.
All right, so let's move away from that. We've been bringing you some of the content from the Steve Biko Bioethics seminar. Of course, today, the 40th anniversary of Steve Biko's death, and looking at pertinent issues affecting our democracy today, so perhaps apt and a special focus on health and the Life Esidimeni tragedy, where over 100 psychiatric patients died, and some of them believed to have been the victims of a move to NGOs, some not even operating legally. So announced today that there will be an inquiry.
We are accustomed and used to the fact that there must be professional accountability in terms of clinical services. But I think as none before, the Ombuds report has pointed out and delineated in many respects the responsibilities and accountability also of other role players such as managers and even political principals. So I think with that, the tone was set really to then just bring the next thought to the table in terms of what did clinicians do or didn't do at the time. And I want to just break that down in terms of individual clinicians, and perhaps then what did we do as professional groups. And so I'm going to allude to a few groups, which including my own societies, South African Society of Psychiatrists, the South African Medical Association, the Psychological Society of South Africa, and other groups like the Rural Mental Health Campaign, group, the People Health Movement, and then also the voices of some faculties of health sciences. So just to allude and give one or two examples of how individuals and groups were involved in the time, and this dates back, I think, to April 2015, where in different capacities, in different line function committees and meetings, clinicians individually and collectively have tried to give the message, try to point out that there may be other actions to be taken, other measures to take into account, including some memoranda that was submitted, in particular some memoranda who requested interviews with the MEC at the time, and also to engage perhaps then from clinicians and trying to bridge the gap, so-called, in terms of reaching out and giving the message across. Also, again, as clinicians in our different cluster meetings, so this is just examples of how in different line functions, I think clinicians have tried to bring information to the table about the situation at the time. If I can allude in a minute just to the specific involvement of the Society of Psychiatrists, I think from early 2015, already April, if I'm not wrong, through to September, there was some reaching out to other advocacy groups like the Society, the South African Depression and Anxiety Group. We have tried to continue with some follow-up statements in anticipation of the International Congress that we've co-hosted in 2016. We've also adopted a program around psychiatry and psychiatrists' social contract with community, which was a little bit of a stretch for us clinicians who's used to just sitting behind desks and trying to get scripts and patients moving, but how to get involved really with social issues. We've tried to orientate ourselves in terms of that in anticipation of that Congress. We took part in other activities. We were one of the respondents in the interdict process that was attempted in March of 2016. And since the Ombuds report, some of us have been involved in the Ombuds investigation itself, as well as some of the task teams of National Department. I can say then, ongoingly, individual members of SASOP and us collectively has, in our line function, then also tried to continue with the daily demands. This is just alluding to our program in terms of the social contract, which was still, and is still a bit of an ongoing project for us as SASOP. To allude briefly to the other societies, we know that the SAMA, the South African Medical Association, has involved themselves in the discussions in terms of 2 media statements at least. The Psychology Society and other societies, various groups have put comments and concerns forward. There are 2 statements from the one Stellenbosch University. Our own faculty has discussed this matter on board level. And not the least of the process was a letter from our WITS 2016, class of 2016 OT students, whose letter also, I think, was added to the collection of voices that I think can be documented as clinicians in the process. In the next 1 or so minutes, I would just like to just allude and consider a little bit our role as clinicians, as advocates. And to preface that, I just want to allude to both our post and undergraduate curricula has been revised in the past years in order to focus on the so-called core competencies that we want to see in our undergraduate students as well as postgraduates, in particular the College of Psychiatrists has embarked on a blueprinting of its postgraduate training as well. And so in both of these processes, the roles of not just to be excellent clinical decision makers, but also to be managers, scholars, as well as advocates, has been identified as a very specific attribute that we want to see in under and postgraduate of our faculty and of the colleges of medicine of South Africa. I'm going to perhaps stop this 5 minutes with just alluding to one or two examples of clinician groups that in the past have tried to collect themselves, collate information, and group themselves in terms of advocacy function. And one example would be this group basically following the TRC proceedings at the time still. This was a group of physicians in Cape Town, the Physicians for Human Rights and the School of Public Health and Primary Care, they call themselves. What is interesting of this group is that they've actually produced a guide and with almost a tick list and a roadmap for clinicians to be followed. And if one use that perhaps as one example of saying, or posing the question whether clinicians in the life Esidimeni process have played up or lived up to the expectations, it may be interesting to look at the website, the references at the bottom there. So the issue that they highlight is just the matter about dual loyalties and scenarios where that comes to the fore, where clinicians are being torn between their loyalties in terms of patient care and scenarios where this may be in conflict and in competition with their loyalties with towards third parties such as employers, or service funders, for example. I would like to just refer to one of the bullets on this slide. They are identifying the dimensions of the problem of dual loyalties in several scenarios. The bottom one there, where the problem arises when clinicians remain silent in the face of human rights abuses against individuals and groups in their care while they had to be speaking up. And then the last point perhaps to refer to is how to assess professional organizations nationally in terms of their contributions on a national level. I'm not sure if you can read that. The screen is not totally agreeable on this side, but I could just point out to the bottom again, it's interesting that point 6 in their list of mechanisms that professional bodies, collective professional bodies, in this case, for example, such as the South African Society of Psychiatrists. What was interesting at the time, they've foreseen perhaps the oversight of an independent reporting structure, such as the Ombuds reports, Ombuds Office. So that was interesting for me to note. Lastly, I would like to just refer then to recommendation 16, which is as follows. The Ombuds has set this, which can perhaps be our guideline in terms of reform and in terms of thoughts in terms of post-life Esidimeni. He has recommended that this investigation has clearly shown that for deinstitutionalization to be undertaken properly, the primary and specialist multidisciplinary teams that are community-based mental health care services must be focused upon, must be resourced, and must be developed before the process is started. It will most probably require more financial and human resource investment initially for deinstitutionalization to take root. Sufficient budgets should be allocated for the implementation. So this is an important but very difficult and complicated statement to unpack on a regional level in all the provinces in terms of how to translate the existing policy into operational action plans. I think I'm running out of time at the moment, Prof. Dai, and so I am going to perhaps move forward from these slides. Suffice to say that, again, following the Ombuds report and post-life Esidimeni, the Society has called for change and overhauling, so-called, of the mental health care system, but according to national health care policy, which we supported from the beginning, and we agreed that this is in place already. The challenge, though, would be for us to operationalize that, and these 5 points only allude to perhaps how to do that in Gauteng on a regional basis, but also in other provinces. I want to stop with this last slide just to be alluding to a recently established Bill of Rights for persons with mental health that the WPA, the World Psychiatric Association, has formulated, and the SASOP is a subscriber of, which just set us on the road of the specific 15 human rights for people with mental health. Let me stop with that. Thank you very much.
Thank you very much, Professor Janse van Rensburg, for this feedback. It's always quite sad that something awful has to happen before we hold this kind of post-mortem investigation of an event. But what I really take away as a very important message from your presentation is the role of clinicians as advocates and the various mechanisms whereby such advocacy roles could and should be served. I don't think we can ever get away from the importance of that message. So thank you very much for that. Our next speaker is Mr. Lucas Mogwerani. Come and join me here. I'll give you a very brief introduction. He is the family representative of the Life Esidimeni families. He was born and raised in Soweto, in Pimville, and studied in various institutions, including UNISA, where he obtained his BCom law degree. In 2005, he founded an NGO, the Greater Orlando Group, which created 12 cooperatives for females and youth. And this NGO is a stakeholder in the University of Joburg. And since the Esidimeni incident, he was chosen to be the affected family's representative. Welcome.
Thank you so much. Without any further ado, all protocol observed. Ladies and gentlemen, time is money. As we are here today, I'll start by saying, as family committee members, my fellow members are also sitting up there. We have created, since this marathon, what we call counseling and, of course, trying to motivate our families. We quote from 1 Peter chapter 5, verse 7, that says, "As long as you put all your sufferings unto me, says the Lord." That keeps us going. Number two, as family representatives, since the so-called Esidimeni post-life marathon, this was not an easy affair to take, of pain, agony, stress, and many other factors. However, we said to ourselves, we should sit around with our local government, our honorable MEC, our also different DGs, the national government, that a pen is mightier than a sword. Going to courts or fighting cannot solve a problem. We are sitting since then around the tables, sorting out, coming up with a solution of the alternative dispute resolution. What is the way forward? Therefore, we discovered that the only thing is to sort out this problem amicably and not pointing fingers to each other. And then we appreciate our government for listening to us, because the essence of the matter is we are having a democracy. And what is democracy? It's a government of the people, for the people, by the people, then the people. That should listen to the government. That is why Madiba used to say, no one is above the law, even the presiding judge. And we are saying, justice should be restored to the wrongdoers from wrongdoing, and then we should have a fair and justified government which will listen to the people. Then we are saying again, this should never happen. And what is important is that our government should be able to listen.
Sorry, it's making such a horrible sound.
Oh, sorry.
Just lift it up a little bit.
Oh, okay.
So
All
that
right.
you don't
So
struggle
it
with
means
it.
I've got a powerful voice, sorry. I'm just like Teddy Pendergrass. Then going forward, life as a demon. Like Madiba said, we must forget, forgive and forget. It's not an easy affair to forget. It's more than the Marikana. It is in fact triple Marikana. Then we are saying, as family committee members and all the members that we are representing, we should think that as we speak today, we commemorate Steve Biko, who also died in agony, stress, and so forth, 40 years ago. We should, together with the family members of Esidimeni, try and share the same pain. And then moving forward will be amicable. We know the government is doing something, talking to us for the first time. This is how the government of democratic system should be doing. Listen to the people, sit with the people, move forward, and have an understanding. Yes, of course, this morning, our former Deputy Chief Justice, Dikau Moseneke, was having a briefing at Mamburu, where this strategy of Steve Biko happened. He was giving a press briefing. So now, together as we are sitting here, we share the same sentiments that now, this is from today, together with our government, we should have an understanding and not allow again such a tragedy to happen. In conclusion, I will quote from one of the verses that I took from the Bible, which says in 2 Timothy chapter 4, verse 9, as I always motivate the students at University of Johannesburg. We have fought our good fight as family members committee. We have finished our race, and we kept our faith to date. So, even those who are still in agony, let's try and tolerate the pain and move forward. With these words from the family members, I thank you. Thank you so much.
So thank you very much, Mr. Mogurani. I think it is admirable to listen to how you speak about the positive tones that can be taken out of this incredible tragedy, and the numbers that we know are enormously high. I really admire that. Our next speaker will be Ms. Rubina Velodia. Come closer. So I'm going to introduce her to you. Rubina is a third-year medical student at Wits University. She's been involved in the Wits Students Bioethics Society since her first year at Wits and is now the chairperson of the society. Her role in the society has included organizing debates and forum discussions aimed at stimulating dialogue among students about bioethics. Topics for these events have included the ethics of the pharmaceutical industry, interdisciplinary cooperation in the health sciences students' legal rights and responsibilities, transformation in health sciences, and alternative medicine. She's just ended her term as the chairperson of the Wits Sports Council and sports officer on the Wits SRC. Rubina spent a month volunteering at the MRC Wits Rural Public Health and Health Transitions Research Unit in Bushbuck Ridge in 2016, which fueled her passion for public health research. So, welcome, Rubina. we look forward to hearing the students' perspective in this matter.
Thank you.
Good afternoon, guests, Professor Vella, and members of faculty, and to my fellow students. Thank you for the opportunity to speak here today. There's so much that I want to say on how we students can contribute to the creation of a just and equitable health system. Because my time is limited, I'll focus on just 3 areas in which we have the power to choose to change the status quo in South Africa's healthcare system. First, what is the status quo? A defining feature of our healthcare system is its skewed distribution of resources. We spend 9% of our South African GDP on health, a figure that is equal to or higher than that in most middle-income countries. However, our health outcomes don't measure up to those in those other countries. And that is because a large portion of the money that we spend on healthcare is spent in the private sector. As the MEC mentioned earlier, an average of 11,000 Rand per person per year is spent in the private sector, and this figure is only 1,900 Rand per person per year in the public sector. This disparity means that people who lack social, economic, and political power are sentenced to a lifetime of being unable to access adequate health care. Because of their lack of power, they are unable to change their situation. Social injustice is quite literally killing South Africans. Our community site visits and clinic and hospital days have exposed us all to this reality. We need to recognize that this unjust system is not immutable and that we can seize the power we have to change it. We health sciences students have been given the opportunity of a professional education. Public taxes are used to fund a large part of all of our degrees, including those of fee-paying students. This is the public investing in us, not only to participate in the healthcare system, but also to change it and to improve it. We're in a powerful position as future healthcare practitioners. We can choose whether we want to use this public investment in us to meet our needs and wants, or to look beyond that and use our healthcare system to create an equitable society. There are a number of practical ways in which we can do this. First, we need to root out the apathy that pervades the student body. There's a group of about 200 students in the Faculty of Health Sciences who both organize and attend every after-hours event, whether this is a seminar or a protest. We will never, ever change our inequitable system if all we can do is recite names of diseases and lists of drugs that will cure them. We need to constantly engage with one another, with faculty, and with our community to share ideas and gain an understanding of how we can work together to improve health outcomes in South Africa. A well-rounded professional who cares about their society would never choose to not engage in politics. Comrade Steve Biko was one of us, a young medical student. His values led him to engage in activism against an unjust system. So, to that student who has never attended an event organized by the Rural Health Club, the Physician Society, the Black Health Professionals Association, or even the ultrasounds, leave apathy and ignorance in your chair in the library one evening, come to an event, and make full use of your university experience to learn the things that no one will teach you in a lecture hall. Second, we need to hold each other accountable to high standards of ethical practice. Health sciences has often been a sort of old boys club in which we protect each other's interests instead of the rights of our patients. We need to rebuild this into a culture of supporting fellow clinicians who speak out against ineffective health policy and hospital mismanagement, but also calling out clinicians who put profit generation and status above ethical practice and commitment to patient care. In March this year, outspoken ANC MP Makosi Khoza, in her role as chair of the Portfolio Committee on Public Service and Administration, exposed the indifference of Hazy View hospital healthcare workers to their patients. An executive from the hospital phoned her immediately after she released her report to threaten her, furious that she had exposed this information to the public. Let us, as future healthcare professionals, make sure to speak out in support of anyone who exposes the inadequacies of our system, even if this means speaking out against our own colleagues. Threats and leadership based on fear and division will have no place in our professional sphere if we band together to speak out against it. We also need to engage with and question our friends who are planning to emigrate or go into private practice as soon as they graduate. In the words of Steve Biko, we have to be prepared to lose our positions of privilege in a bid for change. The conveyor belt that leads healthcare professionals from rural public practice into urban private practice is a huge contributor to health inequity and resource imbalance in South Africa. As a profession, together with government, we have to improve working conditions so that we don't continue to lose committed public health doctors to the private sector. Let's stop that conveyor belt and make the choice to use our education to positively impact the public sector, where we can make the biggest difference towards equitable healthcare. My third and last point is that we need to work together not only to hold each other to account, but to hold government accountable. In 2003, a Dr. Thijs van Mollendorf, a rural doctor working as a hospital administrator in a public hospital in Mpumalanga, was dismissed from his post for going against the government ban on ARVs and supporting an NGO that provided ARVs to rape survivors. Mpumalanga Health MEC, Sibongile Manana, took von Mollendorf and the NGO to the High Court and managed to get von Mollendorf fired on grounds of insubordination. What is most unsettling for me about this story is that his colleagues were not prepared to speak publicly in support of him, even when his actions had a solid basis in the Constitution of South Africa, which grants every South African the right to health care. We need to present a united front as a profession to defend our Constitution and make sure that its provisions are achieved and not just left on paper. This goes beyond just the Department of Health. We need to recognize that health and disease are affected by poor social policies, unequal economic arrangement, and corrupt politics. Government is trying to limit public access to information with the Access to Information Bill. This will affect the ability of the public to gain knowledge on how our healthcare system operates and how to hold those in power to account. I would like to mention the group of WITS OT students who recognized that the patients who were moved from the Life Esidimeni Hospital to various NGOs were being mistreated. Already as students, we have the power to record the injustices that we see patients experiencing when we are at clinics or hospitals and report these to faculty or work together to petition the government. Let us use the power we have as part of a university structure to defend the rights of those who lack social, economic, and political power, and continue to do this in our professional practice. I want to stress that the defense of human rights should not involve fighting on someone else's behalf. We must work to protect the agency of our patients and make sure that they are socially, economically, and politically empowered so that they themselves can influence the system to direct it towards their own needs. So, to my fellow students, let us engage with each other, hold each other accountable, and support each other in working together to achieve a just and equitable South African healthcare system. We are responsible for the evolution of the system in the next 50 years. We need to change the system and not simply fit into it. I'd like to end off with a quote from Nelson Mandela. "What counts in life is not the mere fact that we have lived. It is what difference we have made to the lives of others that will determine the significance of the life we lead." Thank you.
Gosh, with young people like that, how can we not be successful? Thank you so much, Rubina, for reminding us again of our responsibilities in terms of addressing social injustices in a clinical healthcare system and of ways of doing so. So I don't have to introduce Professor Vella again, but we welcome him in talking on the academic perspectives on these issues. Thank you so much.
Thank you very much again, Janine. And I think we should have really asked Rabina to speak last. She clearly has the greatest message. So again, thank you very much. So what one really needs to do in understanding the academic role in these circumstances is to really very quickly again reflect what academic health training environments need to achieve. And they really are very simple and well defined. And the first is that one would expect academic or faculties of health sciences and other academic institutions to train individuals in exactly the characteristics that Ms. Velodia has just described to us. Expect them to be able to manage within the system and appropriately take on the system with all its warts and very other aspects that need change. It is, after all, the manner in which the healthcare professional interacts with society that really is the determinant of the outcomes in that healthcare system. The second that we need to do is that these facilities need to innovate and they need to research. And they do it for very obvious reasons. That is to look at new knowledge, to look at implementing new solutions, but also, I think, importantly, to look at the future and to try and understand what the future brings. And I'll come to the last component in terms of that research and innovation, and that goes to monitoring just now as what I think is really a transformative responsibility. Thirdly, these faculties need to be sustainable and efficient. This is something that has to be around. This faculty now for nearly 100 years will have to be around for the next 100 years. You're not going to manage this imperative if this place doesn't run. And what we clearly as management, but also the people who interact with it, need to achieve is that it's there for the future generations. And then we need to do all of this by embracing our partners. And our partners primarily are the society that we work in. And clearly here, we're talking and thinking about the family that has been, the individuals who've been affected by this set of many issues, but it goes much wider than that. And in our faculties as well, we need to recognize that these partnerships go across the whole world. But it's important that we also, when we're doing this embracing, always ensure that we keep the other aspects that we expected to do, and again, the transformative components, which is the fifth aspect about what faculties of health sciences need to do. Now, the transformative components clearly talk to one of the aspects that is a particularly important component in terms of what we think about in our society, and that is obviously trying to correct the issues that have come out of our past history. But I think that that transformative process needs to be substantially more than just thinking about the demographies, but also particularly thinking about making sure that the societies that have been most affected are the ones that are given the most lift in our interactions. All of this is required for us to achieve one thing, and that we participate in the society in which we serve becoming healthy, and for that reason wealthy. Now I'd like to expand a little bit on this whole transformative component. And in that transformative component, I think faculties have three additional functions. These are the ones that have been taught us by many very serious leaders in the past here. The first is that we need to lead. We can't take what is accepted as a norm within a society that is unjust and not, as faculties, address that. And in many ways, I think that there's a classic example that we already have in front of us, and that is what the Steve Biko Center for Bioethics and Law has done. Comes around, demonstrates to us that there are injustices and our responsibilities to addressing those injustices. The second component is that I think we need to monitor. And this not only in terms of the statistic, but also that we as an organization ensure that what is being done in the society that we're serving is appropriate. And in many ways, I think that we as a faculty need to ask ourselves a question how we manage that in the process of this set of many issues. And finally, one that universities are obviously well known about, but I think we often forget and don't always understand some of the difficulties, is that we have to be advocates and activists, and particularly to do so on the behalf of those individuals who are being bypassed by the mainstream. And again, the group of the people from Life as Said of Many is an important one. Why should the universities be doing this? Why is it not something that one would expect normally in society? And of course we expect it to be normally in society, but universities are unique organizations. They're unique in, I think, three major areas. One, in this country at least, they're public organizations that are here in the interest of society, but don't have the encumbrances that sometimes come through other public organizations. Secondly, that all universities are, fortunately nowadays, microcosms of what happens in society, but with one clear difference, in that the individuals who work within universities are expected to be scholars. And that, I think, is the third aspect, is that the scholarly review of what happens in society is something that should be embraced and should be part of what happens in all universities. And I think that this is often best described by academics, ideally being skeptics, or at least to some degree skeptics at all times, so that when they look at things, that they don't always take it at face value. Finally, I think that this is an organization in which fairness should always be a primary component of what we do. And this fairness requires of us to always look at things intelligently, and as I pointed out already, not to take it always at face value. Clearly, all organizations are not ideal, and clearly one of the things that one can accept in what happened in this faculty is that we also are not ideal in having responded to many of these kind of situations, and it often goes around the usual problem that we have in society, and that is the duality or the dual responsibilities and the dual relationships that we often have. And that's one of the major issues that we have in particularly the Faculty of Health Sciences in South Africa, where our multiple hats often blindside us, or in fact indeed stop us. So what are the solutions? And what we really need to do in faculties, I think, is starting to develop much more nimble, much less siloed organizations that can respond in these kind of situations. Fact is that we already have within faculties such organizations. The classic examples is the Human Research Ethics Committees that have been very deliberately slightly put away at arm's length out of our organization, so that they can take an unencumbered view about many of the things that we need to look. And we clearly have a very strong ethics principle within the human research environment in this country. So I think that that's an area that we're going to need to certainly look at very carefully, and I think we need to be developing similar type of organizations so that we can create the kind of things that Rubina Velodia has just mentioned. I thank you.
Thank you very much, Professor Vella. Again, reminding us about our advocacy and activism roles and using our scholarly avenues and routes to do so within academic institutions and faculties of health sciences. We're now moving on to the panel discussion, and I was hoping that we could invite our various speakers to come and sit here in the hot seats here for some minutes of inquiry and discussion from within our audience.
Which one is the least hot?
The least hot? I'm not so sure.
Can KG come?
So we have about half an hour for questions from our audience, and the first hand that I can see up there, I wonder, do we have, can you take the mic up there for us? Let me just make sure they're working. You've got that. Thank you very much. It's coming up.